So, so yesterday we finished about patterns of resistance in MDR sepsis. So we are going to look today at management of MDR GNVs. Okay. So in the question, if an exam paper comes, they might ask you things like, how do you manage an MDR GNV? What are the resistant patterns that you see in MDR GNV? What is synergy testing? I'm sorry for the typo. Okay. So these are the questions that can be asked pertaining to specific concepts of sepsis related to MDR. Okay, coming to MDR gram-negative bacilli, before understanding how do we treat them, we'll know what are they. Okay, so they are ESBLs, that is your enterobacterials, which are having resistance because they hydrolyze third generation cephalosporins. Okay, they are categorized usually as class A amblers, and they have enzymes like Temonara, SHV, CTXM families. Okay, this is one group of MDR GNB. The second one is your CREs, the carbapenem resistant enterobacterials, because of production of carbapenemases. Okay, again, they can be ranging from class A to class B. Okay, except class C. Okay, sometimes they can be mixture of ESBL and MC as well. So they all come under the category of CREs. Okay, whenever there is a carbapenemase present, then they'll be categorized as carbapenemase producing organism or CRE, carbapenem resistant enterobacterials. The next one is carbapenem resistant Acinetobacter baumannii. Okay, you might be asking, we have already told you earlier about CREs, etc. Why do we have to specify a separate organism like this? I'll be dealing with this in the subsequent slides. Okay, so after this, there is difficult to treat Pseudomonas aeruginosa and Stenotrophomonas maltophilia. Okay, majorly whenever you look at your IDSA guidelines, etc., no, they deal with crab organisms, Pseudomonas, Stenotrophomonas, ESBLs majorly, and CRE. Okay, these are the group of organisms that the primary focus lies on when we are managing MDR sepsis, even in the ICU, especially in Indian scenarios. So how do we classify MDR gram-negative bacilli? They can be based on four major ways. Okay, either by spectrum of resistance that they develop, mechanism of resistance they have, clinical pathogens like how we get our report from the labs, or by WHO priority. Okay, so probably in your Viva they might ask you what is WHO priority pathogen list. Okay, if you remember the critical pathogens, it's more than enough. I'll be discussing each one in detail. Okay, so when we're classifying MDR GNBs by spectrum of resistance, okay, so we all know this, it's very straightforward: MDR, XDR, and PDR. We know MDR is non-susceptibility or one agent in more than or equal to three classes of antimicrobials. In XDR, they are susceptible only to one or two categories. In PDR, they are not susceptible to all agents. Okay, so this is by spectrum of resistance. It's similar for both. It can be GPC or GNB. Other one is mechanism of resistance. Like I told you yesterday, it can be hydrolases, proton pumps, efflux mechanisms, target site alterations, or intrinsic resistance. Okay, so this is by mechanism of resistance. Then comes clinical pathogens. So usually the first two ways, uh, probably the mechanism of resistance we will not get straight away. Okay, sometimes we have to deduct it by the report which we get, and most of the times the uh, AMST report which we get, right, the report usually will tell us what is the organism. Sometimes they broadly would classify it as non-fermenters unless they give us the final report, because when you get an interim report, they will usually mention it as enterobacterials or non-fermenters. Then we'll get a complete report, right? Along with it, some labs also give us the sensitivity at the same time, by which we can come to an understanding whether this patient is having an MDR sepsis, XDR sepsis, or PDR type of sepsis. Okay, so again, when we have clinical pathogens, especially by based on the reporting which we routinely get, we have ESBL-E, that is your Klebsiella pneumonia enterobacters, or your CREs like KPC and DMOXA producing organisms, that is your E. coli. Okay, again, non-fermenters can be Pseudomonas, Acinetobacter, Stringtrophomonas, and Burkholderia. Okay, of lately we are seeing all these organisms becoming quite commonly seen in the culture sensitivity report, majorly because of inadvertent use of antibiotics and probably because of increasing resistance. Okay. So coming to the last type of classification, this is the WHO priority pathogen. If you remember this, well and good, but this is a take home or a brownie point only for your practicals. Okay. So remember the critical priority, this list was actually released long ago in 2017 when we started noticing that most of the antibiotic pipeline is getting dried up. Okay. At the same time, they told that these organisms are the ones which require newer antibiotics at the earliest, and the critical priority is the priority to find a new antibiotics, and unfortunately we have not achieved that even in 2024, and that's the reason WHO reaffirmed that these three organisms, that is carbapenem resistant acinetobacter baumannii, carbapenem resistant pseudomonas aeruginosa, and the enterobacterials, all form under a critical priority list wherein these type of sepsis would be detrimental and will carry a higher mortality rate. Okay, so other groups, if you remember high priority, medium priority, need not remember, but just remember crab, pseudomonas, okay, and CREs, they usually fall under the high priority or critical priority list of the WHO classification. Okay, so this is the way we classify about MDR GNBs. Okay, so you remember the, if you just remember it as ESBLs, CRE, carbapenem resistant pseudomonas, okay, along with stenotrophomonas, that should, and carbapenem resistant acinetobacter baumannii. Okay, if you remember these five, that should be enough. If you write this also, it's good enough. Then you can write routinely how you write for your patterns of resistance. So that will help you gain few marks. Okay, just if at all it is asked as a 10-mark question. So coming to the next part of it. So if at all they ask you, how do you manage this? So questions can be, how do you manage a case of CRE? Okay, if it is carbapenem resistant enterobacteriaceae, first you will tell this is what you're suspecting. These are the group of organisms like E. coli, etc. After that, you'll go to the examination. In examination, you will tell that okay, we'll identify the source, etc., and then you will send in cultures. So what do you do for detection of resistance? Primarily, the first and foremost thing that we do is routine antimicrobial testing. Okay, sensitivity, AST, that is your antimicrobial sensitivity testing. That is your routine micro labs which you do. Okay, so with this, it can be a disk technique or any other technique that your lab usually follows. Okay, and then we will get a preliminary report which will tell us whether this bacteria has a susceptibility or resistance to that particular antibiotic. Okay, that will usually be based on CLSI or UCAS breakpoints, like I mentioned earlier. Okay, that is the first step in detection of resistance. Okay, so first step, once you find this out that there is resistance to one of the carbapenems, then you go ahead for the next one. Okay, so whenever we see for carbapenem resistance, okay, always look for resistance to meropenem and ertapenem. Okay, if at all they say imipenem sensitive, meropenem resistant, that itself you should get a little, steady and see that this patient has already developed a carbapenem resistant organism. Okay, so I told you yesterday about imipenem resistant, meropenem sensitive. All of this, this is a combination, usually because of carbapenemases which are present in that particular bacteria. Okay, so there will be a possibility where one carbapenem will be sensitive, the other would be resistant. Okay, it all basically depends on what is the resistance pattern in that particular bacteria. Once you know that there is a resistance, the next step is to know what type of resistance it is. That is where all your OXA48, NDM, etc., and all your other tests like CARBA-RSA, all of them come. Okay, so you need to do a phenotypic assessment and a molecular testing. Okay, sometimes you can also do advanced techniques like MALDI-TOF. MALDI-TOF, mind you, it is again a phenotypic detection technique. Along with that, there is something called as WGS, that is whole genome sequencing. It's very easy to tell this in theory, okay, but practically these are not routinely available. But for exam point of view, remember this. Okay, first you have to do your routine testing. Okay, you have, if at all your lab has a proteomic MALDI-TOF, it is good enough. Okay, so you do that, then find out whether there is a resistance pattern which is present. Then you send in for molecular testing, and then based on the molecular testing you can narrow down as to what is the resistance pattern, and then you can choose your treatment regimen. Okay. Along with this, remember nowadays we are having something called as whole genome sequencing that will help us understand more resistance patterns. Okay. So getting the resistance pattern is not important. The problem is to treat them. Okay. So that is the whole underlining statement for resistant organism management. That is your MDR or XDR or a PDR. Coming to general principles in management, I told you earlier, okay, you have to write this also in your theory paper. Write about source control, start the patient on empiric antibiotic therapy as much as you know based on your local antibiogram. Please don't forget to use terms like this in your paper, okay? This is what they're focusing on, okay? Source control and empiric antimicrobial therapy based on local antibiogram, okay? These are the words you need to write down. And then you should also talk about optimizing based on PKPD principles. Sometimes you can talk about infusions, especially when you're talking about beta lactam therapies. Okay, so and the use of therapeutic drug monitoring for drugs like vancomycin, etc. Okay, so if you write all of this, you'll probably get some more points wherein you have a structured approach to that particular patient. Then once you get your culture sensitivity report and your resistance pattern, then you can talk about targeted therapy. You can talk about combination therapy or the use of newer antimicrobials. Okay, so what the current 2024 IDSA says is whenever we have an MDR bug in the ICU, especially if it is one of the priority pathogens or the critical pathogens which I mentioned earlier, they need to be reviewed by an ID specialist. Okay, and with this review, we need to come to an understanding as what the next choice of antimicrobial therapy would be. This constitutes firstly antimicrobial stewardship. Secondly, we will understand there will be a person who has sound knowledge in treating such cases, wherein optimal removal of this organism can be achieved. Okay, otherwise probably there will be treatment failure. Okay, so this is one place that you need to focus on when they ask you a question about management of MDR GNB. Coming to the approach of individual organisms. Okay, till now it was all a generalized way. Okay, so you need to write this part for any organism they ask. If at all they ask you CRE, crab, anything, you can write it in, or pseudomonas also, you can write all these things. Then you need to write per se what will you do for that particular organism, starting with ESBL enterobacterials. Okay, the first line, especially in a patient with severe infection, is always carbapenems. Okay, especially if it is an invasive ESBL infection. It is proven by Merino trial. Again, Merino was a trial which was checked to see what happens in bloodstream infections when we give piptaz versus meropenem. Okay, what it showed was piperacillin tazobactam was non-inferior to meropenem, but the take-home point from that trial was if it is a severe ESBL infection in the bloodstream, always prefer carbapenem over BLBLI, that is your pip test. Okay, then what it also said is IDSA says that if it is a non-severe type of sepsis, then alternate medications which are present that can be used based on the particular source of sepsis, whether it is UTI, pyelonephritis, pneumonia, etc. Okay, so all of this comes into question when we choose the antibiotic. So in general, remember, always we are worried about severe sepsis with septic shock. And because patient has a bloodstream infection, remember ESBL bloodstream infection, drug of choice is carbapenems. Okay. So what does the European guidelines and the IDSA 2024 tell us? We'll look into it in detail. Okay. So if it is cystitis, you can choose your trimethoprim sulfamethoxazole or your fluoroquinolones like Ciplox or Levoflox. Okay, obviously carbapenem is going to be susceptible and you can go ahead and use it, but you can keep this as a reserve drug. Okay, sometimes if it is just a cystitis, you can still use a single dose of aminoglycoside or oral fosfomycin. Oral fosfomycin and single dose aminoglycoside are preferred for ESBL cystitis when the organism which is grown is E. coli only. Okay. Otherwise, if it is non-E. coli cystitis, probably you might have to choose a fluoroquinolone or a carbapenem as a standard regimen for around 5 to 7 days. Okay. So that is the duration of therapy which has been mentioned for gram-negative MDR sepsis. Okay. The next recommendation is again for ESBL pyelonephritis or complicated urinary tract infection. Again, here you can give this patient Septran or levofloxacin or Ciplox. Okay, if at all this patient is unable to receive any of the above said antibiotics, then the drug of choice would definitely be your carbapenems. Okay, so alternatively, you can still use aminoglycoside, but it should be a full treatment and not a single dose. I've already mentioned about severe infections. Drug of choice again here would be meropenem. Coming to AMP-Cs in ESBL, okay, we know AMP-C is an inducible gene. It is a plasmid-mediated resistance. Okay, just recall that part when I spoke to you again. Okay, all the space organisms come there. Okay, so what they say is sometimes cefepime can be used. Okay, so but only thing keep in mind this itself can be an inducer. Okay, so in these cases if you find that this patient has severe sepsis, please go ahead and start the patient on carbapenems. Okay, so this is one thing that you need to look into. Okay, what type of organism came? If it is a space group of organisms, then always think that is an AMC producer. And remember, these AMC producers usually have a higher propensity to induce it to the sister generations. So that is the reason it's better to choose carbapenems in these group of patients as well. Okay, so this is about the management in ESBLs. Okay, so the ESCMID actually is a little way back. Okay, they're still not upgraded, but majority IDSA is the latest one. So if you remember one, I think so it's more than enough. Okay, because ESC again there are certain differences which are seen. Probably we might get confused. I would suggest you guys to remember IDSA because that is one thing which is universally followed. Okay, so most of the places it is more or less the same. So if at all there is one take home point from ESBLs that I want you to take, divide it into two major things. Okay, one is severe infections. Okay, especially when I talk about severe infection, it is bloodstream infection. So drug of choice is carbapenems. The other group is whether it is UTI or pyelonephritis. Okay, so if it is UTI, you can still use your trimethoprim sulfamethoxazole or your fluoroquinolones. Okay, so if it is pyelonephritis, also you can use trimethoprim sulfamethoxazole or fluconazole. Fluoroquinolones. Okay, so in these cases, for some reason, if you're unable to use the above drugs, then again you can choose carbapenems. Okay. Then the last one I was telling you about is AMC inducers. So if you see that you have a space group of organism which is growing, and that space group especially is something like Enterobacter cloacae complex, etc. So at that particular time, you can still think about use of carbapenems. Okay. So this is about ESBL. Coming to the next group of MDR GNB, that is your carbapenem resistant Enterobacterales. Okay, so in this, you need to choose the antibiotic based on the type of carbapenem resistance. Okay, so till ESBL, we were very safe. We had our carbapenems present and we were able to give it to the patient. Okay, so we were safe enough. But unfortunately, next we have the next bigger bomb, that is your carbapenem resistant organisms. Okay, in carbapenem resistance organisms, what you need to know is key principle is firstly find out what is the type of resistance. Okay, we all know about the Ambler's classification. Based on that, majorly what we need to know if it is a serine type of a carbapenemase or a metallocarbapenemase. Okay, so the whole thing depends on that, whether there is NDM positivity or a oxa positivity. Okay, or both are present. Okay, all of this is something that we need to know. Okay, newer beta lactamase inhibitors are usually the ones which are chosen. Okay, so especially when there are KPC producers, that is Ambler's class A, you can use meropenem, vaborbactam, imipenem, rilibactam, or ceftazidime, avibactam alone. Okay, if at all we have an NDM, WIM, or an IMP, which is given to us based on the Carbar assay or the molecular testing for resistance pattern, then you need to add what? Astrionum, that is your monobactam to the combination of probably ceftazidime avibactam. As of now, in the Indian markets, even we have started getting Astrianum avibactam. Okay, so that can directly be used. Okay, so as an other savior drug, we have one new one. Okay, that is a siderophore antibiotic, that is cefidericol. Okay, so that is your last resort. So try and avoid giving this as a routine drug. Probably we can start with Astrianum avibactam, and then if we find that there is no synergy for this, probably at that particular time we can think about cefidericol. Okay, so I was talking to you about synergy. Okay, so when do we think about doing a combination therapy? Okay, so whenever we have uh, hit a wall. What do I mean by that? You have a patient having NDM organism, OXA48, and then you thought that we can give this patient ceftazidime avibactam plus astrianum or astrianum avibactam, correct? So before giving this, there is a testing called as synergy testing that we have to do, okay, because to see whether this combination of antibiotic will work for that patient or not. Okay, if at all that testing comes as negative, okay, that there is no synergy, then there will be futility of care. Probably that will not be a good choice. At that particular time, we need to think about combination therapy. And whatever we are talking about, combination therapy is our last resort. Okay, as of now, we don't have great data about it, but definitely we are left with no option. So only combination therapy when we are talking about CRE is a polymyxin based therapy. Either it is polymyxin B, or you can think about the use of colistin. Okay, so we know for urine, colistin is a very good drug of choice. Okay, elsewhere we can use polymyxin. Okay, so this is the role of combination therapy in CRE. Okay, I hope I'm clear. Remember, carbapenem resistant enterobacterials. Firstly, find out what is the resistance pattern, whether it is Ambler's classiae like KPC. If it is only that, go ahead, give ceftazidime avibactam. If it is a metallo-beta-lactamase, like your NDM women imp, then you need to start this patient on Astrianum avibactam. If the person has metallo-beta-lactamase and your OXA48, then you have to again give Astrianum avibactam or Astrianum plus ceftazidime avibactam. Okay, only OXA48, similar to what we do in Ambler's A, we can just give the patient ceftazidime avibactam. Okay, once you get a patient with metallo-beta-lactamase production, if the synergy for Astrianum avibactam or Astrianum plus ceftazidime avibactam is not present, then probably we might have to think about a combination therapy, which is a polymyxin-based therapy. Okay, so this is about CREs. The newer drugs, if you are talking about CRE management, one drug you can remember is a cererophore antibiotic, that is a cefidericol. Okay, so this is about your CRE. So we finished ESBL, CRE. Okay, so this table you can take a screenshot. Okay, so what do we do for CRE in each of the site of infection? If it is uncomplicated cystitis, you can still go ahead and use trimethoprim sulfamethoxazole, levofloxacin, and nitrofurantoin. Alternatively, you can use a single dose aminoglycoside. Okay, definitely all the other drugs like ceftazidime, avibactam, meropenem, avibactam, all of them come into existence only based on the culture sensitivity report and the type of resistance. Okay, so even in pyelonephritis, similar to uncomplicated cystitis, you can use the same regimen. Okay, only when you feel that this patient has non-urinary CRE, especially with the KPC, okay, you have to think about use of Zavicefta, that is your ceftazidime avibactam or meropenem avibactam. Okay, so the rest of the things is what I've already mentioned earlier: CRE plus NDM, CRE plus OXA48, or CRE NDM plus OXA48. Okay, so remember this. If you take a screenshot of this, I think so it should be enough. Okay, okay. So here you can write it as NDM plus minus OXA48. Okay. So I told you about cefidericol. What do we do about other newer drugs? Okay, we have tetracyclines like tigecycline and eravacycline. Correct? Can we use these drugs for any source of sepsis or any site of sepsis? No. Majorly, tetracyclines like tigecycline and eravacycline, the role as per IDSA is only for lung, skin, and soft tissue, intra-abdominal, and osteomyelitic lesions. Okay, Usually your eravacycline or tetracycline is ineffective for urinary infections and bloodstream infections. Okay, remember tetracyclines. This is a very important viva question. Okay, they will ask you, can I choose eravacycline? No. Can I choose tetracycline? No. Okay, if it is a UTI or a bloodstream infection, you cannot use tetracycline or eravacycline. Okay, so keep this in mind. That's the reason I have kept it as a separate slide. Okay, so please remember the role of tetracyclines like tetracycline or eravacycline in CRE is only for pulmonary, skin and soft tissue, intra-abdominal and bone. It's a strict no-no for UTI and bloodstream infections. Coming to the next group of organisms, that is your carbapenem resistant Acinetobacter baumannii. Okay, so we all know this is one of the deadliest high priority or critical priority pathogen in the WHO list. Again, what are the options that we have here? What is IDSA telling? That is what I want you to know. Okay, so as of now, based on the 2024 guidelines, high dose ampicillin sulbactam or plain sulbactam is what is being the first choice therapy which they have asked for crab. Okay, if at all we don't have this, then we can go for a polymyxin based therapy, either your polymyxin B or colistin based therapy. Cefidericol, as of now, has shown some promise, especially when there is resistance to all or poor clinical response to sulbactam based therapy. It can be used as an alternate therapy. Okay, so this is based on a recent trial called as the Credible CR trial. Okay, so CRE, you can use cefidericol. Crab, you can use cefidericol. But crab, again, step one, you need to use high dose ampicillin sulbactam. So what is high dose? We'll talk about it. Okay. So I told you it's a sulbactam based therapy. You can either use sulbactam durlobactam if it is available. If it is not, high dose ampicillin sulbactam is what you need to use. So what is the dose that you need to give? It's a daily dose of 9 grams, okay, of sulbactam, which is supposed to be given to the patient. Okay. So this is the initial treatment approach for MDR Acinetobacter. Okay. So if at all we are using a combination therapy, that is your polymyxin based therapy, what are the things that we can use? Either we can use polymyxin B, minocycline, tigecycline, or cefidericol. Again, for crab, they are telling not to go and use eravacycline. Okay. So cefidericol, whenever we are using, better to use it as a combination therapy, mostly because they do not want resistance to be developed to this particular antibiotic. Okay, so because it's a reserve antibiotic, that is one of the reasons they are telling it to be kept as a combination therapy. Here you can use combination cefidericol polymyxin or cefidericol carbapenems. Okay, you can do any of those combinations. Okay, so as of now, combination therapy is as a last resort in crab as well. Okay, there is no major a trial which has shown that combination therapy is better for crab infections as of now. Okay, so all of this is again based on your antibiotic synergy testing, etc. And a lot of trials have been done to see what is happening with crab infections. Okay, it's not just in India; it's around the world. Okay, coming to the penultimate one, that is Pseudomonas aeruginosa, that is difficult to treat, or carbapenem resistant Pseudomonas aeruginosa. Okay, so newer agents with activity versus resistant to Pseudomonas, what they are using right now is ceftolozane, tazobactam, okay, ceftazidime, avibactam, imipenem, relibactam, or cefidericol. Okay, so the only thing IDSA says is whenever we are choosing these drugs, especially with the BLI, beta-lactam, beta-lactam-based inhibitor combinations, try and use it as an extended infusion. Okay, so especially if the patient is having an altered PKPD, like the patient is having septic shock, the patient is having hypoalbuminemia, the patient is having acute kidney injury. Okay, in all such patients, probably it's better to give this patient the antibiotic as a infusion. Obviously, there are other repercussions and other issues that we face, okay, that we might have to think on a case by case scenario. But remember, IDSA says that it's better to give a beta lactam type of an antibiotic as an infusion. Okay, so coming to the gist of how to treat MDR Pseudomonas. Okay, so they say BLBLI is better than carbapenems when it comes to resistant Pseudomonas. Okay, so whenever we are talking about beta lactams, a high dose infusion therapy, usually over 3 hours, is what is recommended. Okay, so in uncomplicated cystitis, you can start ceftazidime avibactam, imipenem relibactam, or ceftalozone tazobactam. In pyelonephritis, also it is the same group of drugs. So that is about your urinary tract. Coming to the non-urinary type of infections, okay, that time you can use ceftazidime avibactam plus aztreonam or cefidericol based on what the resistance pattern that has been detected. Okay, so this is about MDR Pseudomonas based on 2024 IDSA guidelines. Coming to the last group of organisms, that is your Stenotrophomonas, the best available treatment is three for this. Okay, so either you can go with trimethoprim sulfamethoxazole, that is your Septran, that is usually the standard of care, and sometimes there will be resistance seen to trimethoprim sulfamethoxazole as well. In such cases, what they say is you can use levofloxacin. The other alternative drugs for Stenotrophomonas are minocycline and ceftazidime avibactam. Okay, so data is very limited. Okay, only recommendations are based on case reports which have been seen, especially to trimethoprim sulfamethoxazole resistant organisms. So remember, Stenotrophomonas first line is Septran. Alternatives are minocycline, levofloxacin, and Zavicefta. Okay, so coming to the last part of treatment, what is synergy testing? So I was talking about combination therapies. I was talking about multiple resistance patterns, especially when we have NDMs. And when NDM comes and you don't have synergy for that, what do we do? Correct. So that is what we need to understand. So firstly, what is synergy testing? Synergy testing is a laboratory method used to evaluate the combined activity of two or more antimicrobial agents. Okay, against sometimes a resistant organism to see if the effect is greater than the sum of each drug alone. Okay, so they just want to see if 1 plus 1 adds on to 3 or more. Okay, something like that, just a rough estimate. They just want to see if this combination works against that particular MDR sepsis. Okay, so majorly it is useful for MDR or XDR. Okay, so PDRs also you can go ahead and use it. Okay, just that we need to see if the combination therapy breaks the resistance pattern. Okay, so when do we use it and in which organisms do we use it? We use it in CRE, we use it in crab, use it in difficult to treat Pseudomonas. Okay. So susceptibility options in these organisms are very limited, and that is the reason we do synergy testing for all these organisms. Okay. So what are the synergy tests that we use? One, I told you earlier, polymyxin based therapy or a tetracycline like a tetracycline based regimens. Okay. So usually both of them are tested with drugs like carbapenems, rifampicin, aminoglycosides, and sulbactam. Okay, so you can do a permutation combination and then check. Okay, for this. And how do they do that? Okay, there are multiple ways they do a synergy test. Okay, the most common one is a checkerboard assay. Okay, so what they do in a checkerboard assay is they calculate something called as a fractional inhibitory concentration index or FICI. Okay, so if at all there is synergy which is present, the FICI value should be low. That means to say the clearance is better. Okay, so less than or equal to zero point 0.5 indicates synergy. If it is between zero point 0.5 and 4, then it is indifference. If it is more than 4, it is antagonism. Probably there is no effect. Okay, so this is one way of doing synergy testing, checkerboard. Okay, remember FICI, that is your fractional inhibitory concentration index. Okay, so serial dilutions of two drugs are used in wells. Okay, so these wells, they see how they are able to achieve clearance. Okay, other ways is time to kill assay, e-strip crossing. Okay, molecular rapid techniques, etc. Okay, so all of these are methods to do synergy testing. Okay, so remember synergy testing for difficult to treat organisms, especially Pseudomonas, CRE, and crab. How do they do it? Usually they use a checkerboard, time to kill assay, e-strip, or molecular methods. Usually, I told you earlier, it is for crab organisms, CRE, okay, to see whether colistin plus meropenem has some effect, sulbactam colistin for crab, Astrinum plus ceftazidime avibactam for MBL, that is your NDM type of resistance. Okay, so remember, in vitro synergy is not a guaranteed clinical efficacy. Okay, so usually when you do a synergy testing, if it comes negative, sometimes you should still go ahead and give that drug and see if you have no other options. Okay, sometimes there are other mechanisms by which the drug can act. So at that particular time is where we come with understanding that combination therapy is the only way forward. Okay, we are left with no other option, and out of desperation we are doing that. Okay, so remember, synergy testing is not a gold standard test to give treatment to that or a person. Most of the sanity testing is a lab-based testing, so we do not know what the in vivo conditions are. Okay, so that is one take-home point and one of the limitations for synergy testing. Okay, coming to summary of management of MDR sepsis. Okay, MDR sepsis. Firstly, what do we do on an immediate basis? Assess the severity, remove the infected lines, source control, etc., like we do for any case of sepsis. Start the patient on empiric antibiotics based on the local antibiogram with assessment of risk factors. Okay, this is something that we need to write in your exam paper. Then go ahead, do your routine testing like antimicrobial sensitivity testing, followed by resistance pattern if at all there are any. Then, based on evidence, especially the latest IDSA protocols, you can go ahead and treat this patient. Okay. So remember, probably beta-lactam antibiotics better to give it as an infusion in severe septic patients. So that is one way to optimize your PKPD principles. Also mention about therapeutic drug monitoring wherever it is necessary, especially for aminoglycosides, vancomycin, etc. Okay. So whenever you have patients with CRE or CRAB, as of now, IDSA is telling that it's better to isolate these two group of organisms because there is increased risk of transmission. Okay, so this is about management of MDR gram-negative sepsis. So as a take home, I would want you guys to take a screenshot of this. Okay, so most of you would be thinking, what are the other newer antibiotics which are present? What can I give? Correct. So you can take this and use this as a guide to read up and use it as a routine practice as well. I'll be sharing one article after the class today wherein you can read about it as well. Okay, it's one of the articles which was published in January, I think so, in Lancet, if I'm not wrong. Okay, I'll share it with you guys. Okay, so how to approach an answer? Define and classify what is the problem, error it's present, mention the patterns of resistance, outline the general approach to septic patient like your fluids, source control, culture sensitivity, identification, all the routine sepsis management. Then talk about specific antimicrobial therapy, mention newer drugs. If you write the dose, excellent. If you can't recall, don't worry. But I would suggest you to please recall. Okay. And if at all there are trials like the Credence trial, which I mentioned earlier about cephedricol, okay, Merino trial, all of this, if you can remember, please remember and write them. Okay. So this is about management of MDR sepsis.